such an honour and a total surprise. And I guess Linnell and Sin, you must have told a really good story. So thank you. But thank you also to my colleagues who, I mean, this is a team effort. We haven't done this on our own, and I'm looking at my team and my family. And where are you, Candy and Lynn, who are here tonight? As Jill said, my family are here, but also the team that really helped me do a lot of this. So thank you guys, and it's got to be special thanks to my poor family who've put up with me trying to do this and have been really supportive and encouraged me. So that's the thank yous. I would also like to, as everyone else has, acknowledge the traditional owners, the Ngunnawal people of the land on which, the beautiful land on which we are meeting. It reminds me how much I'd love to live in Canberra when we drive through it. But I'd like to go back to Sidney Sax, because one of the lesser known facts about Sidney Sax is when he moved from South Africa to Australia in 1960, he worked as a general physician and geriatrician at Lidcombe Hospital and Geriatrician Hospital in Sydney, both hospitals specialising in older people. Lidcombe kind of got swallowed up in Bankstown, but Geriatrician is still there. And I think it's important because he was one of our first geriatricians, long before we even had geriatricians. He was appointed as Director of Geriatrics for New South Wales in 1964. And that's really important, particularly for me, because in that role, a couple of years later, he was approached by Dr. Richard Jeeves, a general practitioner from northern Sydney, who also worked at Hornsby Hospital. Dick, or Dr. Dick as he was known, he even has a street named after him. Dick was looking at developing a service for older people based in the hospital but working in the community. And look, back in the 60s, this was a totally new and very revolutionary idea. So he spoke with Sidney Sax, and Sidney Sax gave him some really good advice and a lot of encouragement. And in 1968, Dick set up the Hornsby Ku-ring-gai Geriatric and Rehabilitation Service. It started in a little cottage in the hospital grounds, but Dick being Dick, it grew rapidly to inpatient beds, outpatient services, and most importantly for all of us probably, a very strong community multidisciplinary team, which became the model for Commonwealth-funded geriatric assessment teams, which we now know more politically correctly as aged care assessment teams. So it was Sidney Sax that advised Dick, and it was a Dick's team that Warwick Bruin and Glenn Rees came and looked at, and it was used as a pilot, as the model. And Hornsby was a pilot for that geriatric assessment team in 1987. And I, as a newly minted geriatrician, joined that team in 1987, and I'm still there 35 years later. So thank you, Sidney Sax, because you are indirectly responsible for about half my working life. Dick Jeeves' philosophy was very much, if you see a problem, do something about it. And he was way ahead of his time in lots of ways. He knew that if you wanted to achieve something, you had to get all the interested parties in the room, get them talking, and that was a way to succeed. He actually had older people on his planning committees. Now, this is way back in the 60s when consumer involvement did not exist, but he realised you needed to have people who were, they call them stakeholders now, but the participants, you needed to have them really involved. Dick was incredibly successful because he was so inclusive, and I think that's a really important lesson for all of us when we try and do things. Dick worked very closely with general practice because he came from general practice, and his father was a general practitioner also in Pennant Hills. He understood very definitely that GPs are the linchpin in the care of older people. And 54 years later, our service is still working very closely with primary care and with our Sydney North PHN who nominated me. So again, thank you guys. it's really interesting because Dick's philosophy of, if you see something, do something, was drilled into all of us and into the 3 directors that followed him at the service. And all 3 of those directors are in the room tonight. Dick died 2 years ago, but his spirit is most definitely with us. And anyone that knew Dick Jeeves would know that. As I said, he's got a street named after him in Jeeveston, which was founded by his grandfather in Tasmania. Dick's philosophy has really, it's what's pushed or led me, I won't say pushed me, but also my colleagues, Ian Cameron and Cesar Yui, who the other 2 directors of the service. Cesar is still the director and an incredible support to everything that we do. Anyway, that's enough about that. I would just like to talk a little bit about 3 areas of my work that have involved healthcare policy and practice change. In 1989, so 2 years after I started, most of my work was in the community. And I did a home visit to an older man who was living in northwestern Sydney with his niece. And the GP referral was very interesting. It was a GP I knew very well, but the GP referral simply said, "Dear Sue, please assess, something funny is going on." And he was absolutely right. This man was being locked in his room at night by his niece and physically assaulted if he came out. And his niece was collecting his very significant police pension. I had a student social worker with me on that visit, and she'd just done a placement in child abuse. And she said to me as we're driving back to the hospital, "Sue, this is child abuse at the other end of the age spectrum." And I bless Christy Charlin because she was absolutely right. I got back to the hospital, none of my colleagues had heard of this sort of abuse. We didn't have Google in those days, so I went to our medical librarian and told her what I was looking for. And she found a whole lot of information from the US on elder abuse, which was actually, quite well known there. I hadn't heard the words, I hadn't heard the term, and I'd been working with older people for 10 years. So we realised we were simply not recognising cases of abuse that we were seeing every day in our practice because it's a hidden problem. So following Dick's adage of do something, colleagues, including Ian, and I published a case series of cases of elder abuse in the Medical Journal of Australia in 1991. It did cause some issues. People told us we were sensationalising, it was rubbish, it didn't really happen. It was quite interesting. You've got to develop a thick skin sometimes. But we followed it up with a local and then a national prevalence study, and governments actually sat up and took notice. And we had working parties and task forces and inquiries, and as you do. But the important thing was we brought elder abuse into the public awareness. And I think now we all know about it. It's very definitely a medical, social and legal problem. Every state has developed responses. New South Wales was pretty slow. It took us 20 years to get our elder abuse helpline up and running, but it is, and in fact now we have the Ageing and Disability Commission, so we've actually done very well. And I think my comment would be you've got to have a lot of patience and optimism in this job, and you've got to, as I was saying to Gillian earlier, you've got to take the long view. 30 years later, I can say it's definitely been worth it. I continue to see cases of elder abuse in my day-to-day practice, and I am now using those services that we have in place. The problem of elder abuse is not going anywhere anytime soon, but it's really nice that we now have something that we can do about it. Second piece of work, and Gillian's already mentioned it, is, and we brought a lot of players together in this, is geriatric outreach services. In 2004, I was part of a GP panel looking at how do you keep your older patient out of hospital. And one of the GPs commented that it was older people from residential care that we needed to keep out of hospital, because when they came into hospital, we looked after them so badly. When they were discharged, they usually had more problems than they were admitted with. And, pressure injuries, falls, fractures, multi-resistant staph infection, functional decline, the list goes on. And I mentioned this conversation the next day to my then general manager of the hospital, and he just looked at me and said, well, what are you going to do about it? So we realised we had to have a different model of care. We had to look after people in residential care rather than bring them into hospital where we could. So we got a working group together, and it was a lot of the directors of nursing of residential aged care facilities, GPs and representatives, community reps from the then Division of General Practice, which of course the divisions of general practice were before the Medicare locals, and of course Medicare locals are now primary health networks. And we had Ambulance New South Wales, we had our emergency department, we had community nursing, and of course our staff involved in those working groups. The Division of General Practice actually did a survey of all the local residential aged care facilities, I'll call them nursing homes, and we found three things, none of them surprising. One, communication was terrible between hospital and residential care. Second was that they needed more practical support and advice, both for the residential care staff but also for the GPs. And thirdly, that there was actually very strong support for keeping older people in the residential care facility because that's their home and that's where, it was familiar to them. We had 9 months of meetings. This did not happen overnight. Lots of discussion, but we came up with a model of care that did support residents and residential care staff and GPs, basically by providing a single point of contact. And we call this the GRACE model of care, Geriatric Rapid Acute Care Evaluation. And the model was basically a clinical nurse consultant and other nurses who were available from 8 to 8, 7 days a week, to provide advice to residential care staff. It could be face-to-face or over the phone, to provide equipment that they might need. It might be dressing packs, it might be IV fluids if we were doing subcut fluids. We also developed a flip chart, a decision tool. So on the first page you would have chest pain. What do you do? Shortness of breath, all the different areas. And that helped staff make decisions to decide, should they ring the ambulance? Should they ring the GP? Do they ring GRACE? We also made sure you had quick access to a geriatrician. And we still do that. Thank you to the PHN again, to this day. The GRACE position then was located in the emergency department, and Gillian came and visited and actually saw it at work. And they had that dedicated phone line there, which was very useful. But if a residential care facility resident came into hospital, the GRACE nurse would facilitate their assessment and admission if that's what they needed. You could fast track it, and so these poor residents who spent up to 25 hours on average in the emergency department prior to GRACE were spending less than 8 hours. We had a really good comms plan. I've learnt that. Thank you again to the Division of General Practice. We had newsletters and we had meetings and we had emails, and we did academic detailing. So we had GPs going out to other GPs saying, this is what's available. And that really worked very well. We started in August 2005. We evaluated it in August 2006. We decreased the number of residents coming in overall by 30%. What was important is those that did come in, most of them, 80% of them, ended up going back very quickly. That 25 hours that they languished in the ED had got down to less than 8. But I think the thing that counted most was when you looked at the number of hospital bed days, hospital bed nights, used by residents, it dropped from about 600 a month in July 2004 to 291, I think it was, in July 2005. And the best thing for our managers was that access block improved dramatically. So it really did work. The model of care was actually written up by the Clinical Redesign Unit at New South Wales Health, so it got out there. And as Gillian said, it's been picked up across by hospitals across Australia. People don't seem to like using the name GRACE, except the ACT. Thank you, Marianne, wherever you are, because Marianne's a geriatrician here. They took the Grace model of care, modified it for Canberra, and it's now, I've heard, right across Canberra. So they kept the name, but Geriatric Flying Squad, Aged Care Rapid Response Team, lots of different names, but they're all basically doing the same thing as Grace. 17 years later, our Grace team continues to provide a really good service, but with advice from our primary health network, we have expanded to also include older people living at home in that program. The concept of outreach teams is in recommendation 58 from the Aged Care Royal Commission. So our hope is that more of those services are going to be funded in the future. We have a really good blueprint available, I can tell you. The third area of policy and practice that I do want to mention, Gillian also mentioned, and that's the one that probably gives me the greatest pleasure, and that's the concept of intergenerational practice, which is simply bringing two generations together in a care setting or a social setting or an educational setting to the benefit of both groups. And I think that's what's really important. And I knew that there were childcare centres in some aged care facilities, certainly in New South Wales, and I knew that playgroups were happening in some aged care facilities in New South Wales and Victoria, but it wasn't common practice. So we funded colleagues at Griffith University to do a literature review, to find out what is actually happening in this space. Is there evidence for it? And so when the ABC came calling to say, what could you bring older people and children together, because it sounded like a good idea, we were able to say, yes, there is evidence for this. But I'd personally seen the effect that my granddaughter had when she visited my mother who had dementia and was living in residential aged care, and the effect, and am I right, Dave and Bree, parents of my grandchildren, and my daughter's there too, although, Charlotte came as well, the magic effect that those children had, not just with their great-grandmother, but with all the other residents in that facility. I'd been a real proponent of animal-assisted therapy, i.e. dogs, going into residential care. I can tell you kids are really terrific as well. You just can't put them on a lead like you can with dogs. So I got involved with the ABC, and this is something that happens. I say to colleagues, if an opportunity comes up, grab it, because you never know where you're going to end up. And if anyone had told me I'd be, on national TV, I would have told them they were dreaming. But as it turned out, we organised Old People's Home for 4-year-olds Series 1. We filmed it in late 2018. It went to air in mid to late 2019. We filmed it in a retirement village, so with older people who were quite frail, and some of them were in supported accommodation. And I don't know how many people here haven't seen it, but I think if you have seen it, you would know that the response and the results were absolutely amazing. I don't think any of us expected the wonderful relationships that developed between the children, the 4-year-olds, and the older people, but also the benefits in physical health and psychological health, mental health. I think what's important is those improvements were sustained, often to within days of the older person's death, because we've lost a few of those first participants, but those relationships are still going on 4 years later, which is really, really lovely. The success of that series, and remember this is pre-bushfires and pre-COVID, it meant that a whole lot of residential aged care facilities wanted to do intergenerational care, and we had a number that developed play areas and were getting all ready to go, and then along came COVID. And everything went on hold, and everything is still on hold, because 4-year-olds cannot go into residential aged care because they are not vaccinated. So roll on vaccination of the young ones, because it is quite important. But with Series 1 being really successful, the ABC decided, despite being very risk averse, to film a second series, which we filmed in the eastern suburbs of Sydney, bringing people in from their homes. And these were older people living alone. So social isolation and loneliness were a real focus, as well as physical frailty. We really wanted to look at that. Again, we saw the most amazing improvements. And again, those relationships have continued, which is really lovely. Old People's Home for Teenagers was a real step into the unknown. We filmed that early this year and it went to air, it's just finished going to air, and I have to admit to being quite worried about whether it would work or not. My sister, who's here tonight, is a school teacher, and we had a few conversations, didn't we, about teenagers? But I think we got the right age group, and I was just amazed the way those older people and teenagers interacted. And I think we're all pleasantly surprised, and the benefits are very much there. And those relationships are continuing. They actually got together about 3 weekends ago, I think at the end of the school holidays, for a get-together. ABC loved it because even before the last program went to air, they commissioned another series of Old People's Home for Teenagers. And we're going to try and do this in a community centre so that the activity can continue after the filming's finished, because it's all very well to have a really nice setup and do the program, but you have to have it so it's sustainable, and I think that's really important. So making intergenerational programs part of aged care, a mainstream part of aged care, I think is really important. Residential care, but also community care. And I guess that really is probably one of my most important goals. It is such an effective way to make a difference to the lives of older people. There's a lot of research going on in this space. How long should the programs be? What sort of content should there be? What are the barriers and the enablers to doing this other than COVID? University of Canberra has got quite involved, and this really is a family affair because my daughter-in-law, who is a lecturer at the University of Canberra, is involved in a program, and Minister, this will interest you, at IRT Kangara Waters. And they have just started a playgroup visiting on the croquet lawn, is that right? Croquet lawn, sorry. Because of course the children can't go in to the aged care facility. But if you think flexibly, you can find a really good way to do it. Griffith University, University of New South Wales and Uni of Sydney, where I am, we're all involved in looking at it. But we need more community people involved if anyone's interested. So there's masses we can do in aged care. I think that'll keep me busy for a while. I haven't touched on successful ageing or dementia or frailty, although we sort of looked at them a bit in intergenerational care. But I have to admit, to confess, to quite a degree of self-interest here, because I want to make sure that there are really good programs and services in place for when I go into aged care. With that confession, I will say thank you again, and I would be happy to answer any questions. Thank you.
We do have some time for questions, if anyone has some. Susie.
I think that relationship my children have with their parents or grandparents in the past. Is there any research happening into the benefits that's from the children's perspective, like benefits to the children engaged in the program?
The Carol Ewell was the psychologist who's been involved in the second and third programs, and we did that to look at the benefits to children. And I think there was certainly an increase in confidence. You could eyeball that children became more confident. There is quite good research that shows that ageism is reduced if you are exposed to that constant, the 3 generations or sometimes 4 generations. The empathy was the thing that they concentrated on in Series 2, and there was an improvement in empathy. So there are some definite positives, but I think it'd be good to do maybe a little more work in this area to encourage there to be more of it. I was saying to colleagues earlier, we used to have volunteers in kindergartens, in schools, but there are so many regulations. You've got to have insurance. You've got to have your working with children check, your working with vulnerable people check, your police check, all those things. Kindies just don't want to buy into it anymore. And that is a real pity because there's lots of volunteers out there. I got more than 1,000 emails after the first series of people asking how they could be involved. And, the children's side of it, because I'm a geriatrician rather than a paediatrician, but we know it's good. And as the grandmother of, 4 grandchildren, I saw how beneficial it could be. So I think we should be doing more of it, and it's definitely, evaluating it is the important thing, so we can say, yes, it is good. Shout.
Thank you. Fabulous presentation, fabulous award, well deserved. One of the things we've been talking about over dinner is the destigmatising effect of the program, particularly about bringing kids and older people together. And this might be a strange question to ask a geriatrician, but I'm interested in the reverse effects also, the kind of stigma we have about children and young people and what you've observed from that program in terms of bridging that stigma across the generational divide at both ends.
That's a really interesting question because ageism does not just affect older people. And while ageism towards older people is the most common, the second most common group is teenagers, where there's ageism. And that was really interesting. And one of the things we did in Series 3 with the teenagers was at the beginning we asked them for their words to describe older people. Frail, old, weak, slow. And then at the end we asked them for their words. Fun, open, honest. And look, it was just amazing, the differences between the two. We know that there's research, as I said, that shows if you expose children to lots of contact with older people, it does help. But it's how we do it best that's a really important thing. But that stigma, we see it with dementia, but with older people generally. But we all want to get old. This is what bugs me. People talk about the silver tsunami. I have never met anybody that doesn't want to be part of that one day. No one wants to die at 60. And yet there's still that underlying ageism. And as someone that's just turned 70, and thank goodness I was then eligible for the antivirals because I got COVID 5 days after I turned 70, which was good. So there was one positive. But it really is an issue. And I think we have to address that because there's lots of us want to get old and enjoy getting old. But with the teenagers, I think it's really interesting. We've got to work out how to have that contact more.
Question from the family.
Oh.
You said that everyone you met says they're wanting to get old. Yes, this is not a contradiction of your term. As being an emergency physician, I'm constantly told by countless patients, never get old. It's not fun.
Yes. I think that's more an observation than but it's funny. It's true. Don't ever let me get old. Shoot me if this happens. You hear that often, and yet when people get older, they actually can be quite contented. We saw this with my mum, who had dementia. She was in aged care for 6 years. She was actually quite contented, and yet I think she would have been horrified, wouldn't she, Rob, to think that she had dementia. But we never actually told her straight out. And when she failed her memory tests, she would just say, "Oh, I'm so careless." And it was a much better way to look at it. But I think we adapt as we get older, and thank you, Rolly, for that comment. But you're right, getting old can be a bugger. And that's where I come into the successful ageing. And how do you age successfully? And I won't go into that tonight, but the bottom line is basically exercise and staying mentally active. So yes, and there's my physio daughter saying yes, yes, yes. It's tough. I worry that older people don't want to get old because they hate the way you in the emergency department look after them. So thrown back at you, mate. And I would have to say at Hornsby, where Rolly works, they are wonderful in the emergency department. Yeah, definite bias, yes.
Well, thank you so much, Professor Kurrle, for... Thank you so much for sharing what I'm sure is only a tiny snapshot of the contribution that you have made to the well-being of older people. I would like to congratulate you on your contribution and your enthusiastic advocacy in responding to one of the most significant and ongoing health challenges of our time. For those who have been with us all day, you are the epitome of what we've been talking about. Leadership, the culture, flexibility, persistence. You know, this is what we're talking about, and it's no surprise that you have been awarded this medal. It really has been a privilege to have you in person here tonight, and to have been able to listen to you about your wisdom and passion for the health and well-being of older Australians. So once again, can you join me in thanking Professor Kurrle?